Sir, shall we start, sir?
Oh, yes.
Yes, sir. Let me do the introduction, please. So, dear participants, very good evening. Welcome you all to the 10th session of this FTP. Today we have with us a very distinguished academician, Dr. Varun P. Gopi. He is an esteemed academician and researcher, currently serving as an assistant professor grade 1 at the National Institute of Technology, Trichy. With a robust academic background and specialization in signal and image processing, Dr. Gopi brings significant expertise in areas such as medical image processing, artificial intelligence, IoT in healthcare, augmented reality, and compressed sensing. Dr. Gopi qualifications include a BTech in Electronics and Communication Engineering with the first class distinction from Amal Jyoti College of Engineering, Mahatma Gandhi University, followed by MTech in the same field uh, from uh, from the College of Engineering, Trivandrum University of Kerala. He completed his PhD in 2014 from NIT Trichy, specializing in medical image processing. His research interest covers a wide range of cutting-edge topics, including IoT applications in healthcare, the integration of augmented reality in medical system, and the development of hardware solution for a deep learning application. Dr. Gopi's contribution to the field of signal processing, medical imaging, and artificial intelligence have made a significant impact on the advancement of healthcare technologies. So, welcome you, sir. Over to you. Thank you.
Thank you, sir. Am I audible?
Let me stop my screen sharing. You can share your screen, sir.
Okay. Am I audible?
Yes, sir, you are audible.
I hope the slides are visible, right?
Yes, sir, visible.
Okay. Is it moving? Okay.
Sir.
So, good evening, all. Today I'm going to talk about introduction to intracranial hemorrhage and its classification using deep learning. So, initially, we will go through the basics of intracranial hemorrhage and its different types and the causes and symptoms, followed by a few applications using deep learning, the classification using deep learning. So let me start with the intracranial hemorrhage or ICH. So this ICH refers to any bleeding within the skull, and it can be classified into several subtypes based on the location of the bleeding. Basically, it's a kind of bleeding within the skull, and we can divide it into different classes. If you look at on the left side, you can see that there is a subarachnoid hemorrhage, intracerebral hemorrhage, intraventricular hemorrhage, subdural hemorrhage, and epidural hemorrhages. These are the main 5 categories. So when you come to this picture, you can see that the first one is intrapharyngeal hemorrhage. This is actually comes under the intracerebral hemorrhage. Okay, this is a kind of intracerebral hemorrhage. And here, if you see the location, it is inside the brain. So this is the location where we can see this intracerebral hemorrhage. And next is the intraventricular hemorrhage. So here it is inside of the ventricle. If you look at here, you can see that inside the ventricle there is a hemorrhage. And for subarachnoid, it is between the arachnoid and the PA matter. So if you look at here, this is the region for this particular hemorrhage. And subdural hemorrhage, it is between the dura and the arachnoid. So if you see, this is the region where we are getting this blood flow. And finally, the epidural, that is between the dura and the skull. So this region. So these are the 5 different categories. And now we can see the mechanism, what causes these problems. For the first one, intracerebral, main reason is the high blood pressure, trauma, or atriovenous malfunction, we call it as AVM or tumor, etc. And when we come to intraventricular, it is associated with both intraparenchymal and subarachnoid hemorrhages. And third, for subarachnoid, it's a rupture of aneurysms or arteriovenous malfunctions or trauma. So these are the causes. And subdural, it is due to trauma. And epidural, it may be either trauma or after surgery. This may happen. The main source is, for the first case, is arterial or venous. Similarly, for intraventricular, same arterial or venous. And for subarachnoid, we can see that predominantly it happening in the artery. And in subdural, it is happening in the venous system, especially in the bridging veins. And epidural is in arterial. And the shape, based on the shape description, we can identify. So if it is typically round shape, it may be intrapharynghymal or intracerebral. And if it is conforms to ventricular shape, we can see that it is intraventricular. And it tracks along the sulci and fissures. So we can assume that this is belonging to subarachnoid. And if it is subdural, it is in the crescent, this side. And if it is epidural, it will be on the lentiform. So these are the shape descriptions for this different category. And when we consider the presentation, it will be acute for the first case, that is sudden onset of headache, nausea, and vomiting. So these are the causes or symptoms. And for intraventricular, same acute, that is sudden onset of headache, nausea, and vomiting. And for subarachnoid, worst headache of life. That means you never face such kind of a headache. And subdural, it may be insidious, that means worsening headache. Initially, it may start slowly and it will go further, very deep. And for epidural, it is acute, that is skull fracture and altered mental status. So these are the main different categories of intracranial hemorrhage. And now we will see one by one in detail. So first of all, before going to the details of each category, we will see the cause of intracranial hemorrhage. The first one is trauma. So trauma means it may be a falls or accidents because of the exposure of head to a particular space or maybe falling, anything, any accident that creates trauma. And second thing is aneurysm rupture. And third one is arteriovenous malfunctions or AVMs. And fourth one is hypertension. It may be chronic high blood pressure leading to vessel rupture. Then the next one is coagulopathy. That means blood clotting disorders or anticoagulant therapy. Then brain tumors. The important thing is the substance use. Example, cocaine or amphetamines, if people are using, this may cause intracranial hemorrhage. And finally, the stroke. The stroke may be ischemic stroke converting into hemorrhage. Initially, it may be ischemic stroke. Later on, it will be converted into hemorrhage. So diagnosis, how we can diagnose this disease? So first thing is the CT scan, that is non-contrast CT we can use for identifying this. This is the most common and fastest way of detecting bleeding. And second option is MRI. So this MRI provides detailed imaging, particularly for smaller bleeds or areas missed on CT. So as you know, CT is mainly good for bone scanning, but MRI will be good for soft tissue scanning. So if you want a more detailed structure of the bleeding, you can better go with MRI. And third one is angiography, which is used to identify small aneurysms, AVMs, or other vascular abnormalities. If any vascular abnormalities happen to the vessels, so angiography will be the best option to identify. So these are the basic diagnosis methodologies for ICH. And now we are moving to each one. That is subarachnoid hemorrhage we are going to see first. So in subarachnoid hemorrhage, it is a type of stroke caused by bleeding into the space surrounding the brain. So known as the subarachnoid space. Okay, so here This space contains the CSF, that is the cerebral spinal fluid, which gives us balance. So the bleeding often results from rupture of an aneurysm or trauma and can be life-threatening. So this may be happen due to aneurysms. That means breakage of small blood vessels, or trauma, maybe due to accidents or fall. If this happens, it is a life-threatening issue. And symptoms are like sudden severe headache, commonly described as the worst headache of my life. That means we cannot bear that much pain. It will be like that. And next is nausea and vomiting. The third symptom is the neck stiffness or pain. And fourth one is the sensitivity to light. We call it as photophobia. So if light strikes on the eye, it will be very difficult you to face that. Then loss of consciousness or confusion, then seizures, and weakness or numbness in part of the body, and vision changes or double vision. Sometimes, if a person is affected with the subarachnoid hemorrhage, he feels like seeing everything in double vision. So, the main cause for this subarachnoid hemorrhage is aneurysmal SH, that is subarachnoid hemorrhage. It is a rupture of cerebral aneurysm. That means weakened or ballooned artery wall. So, when ear goes, there will be chance of weakening the vessel thickness, or vessel will be weakened, or it will be go in a ballooned structure. So this may lead to subarachnoid hemorrhage. The second one is traumatic. That means injury to the head causing bleeding in the subarachnoidal space. And third one is non-traumatic causes. Conditions like arteriovenous malfunctions, AVMs, blood clotting disorder, or high blood pressure. Sometimes if the people having some high blood pressure and it is beyond the limit, sometimes the veins may break and bleeding will happen. So this time it is non-traumatic, but it is still comes under the subarachnoid hemorrhage. So we will see AVM and aneurysms in detail in the upcoming slides. Then role of radiologists in SAH. So in diagnosis and determining etiology, assessing the complications. So we need the radiologists to assess the condition. Radiologists play a critical role in confirming SAH through imaging and identifying its underlying cause. Example, whether it is an aneurysm or AVM or it's a blood clotting, and evaluating potential complications like rebleeding or hydrocephalus. Sometimes initially maybe bleed and stop for some time, again it may rebleed. So if you analyze, then only you can identify the cause. What is the cause behind the rebleeding? So that can be analyzed using the medical imaging. So for the diagnosis, the first thing is clinical examinations. Based on the symptoms and the neurological deficits, we can identify. That is first thing. The second thing is with the help of imaging studies. So first, as I told earlier, CT scan, that is non-contrast. There will not be any contrast agent injected. Without contrast agent, that is non-contrast. First line image. This is a first line imaging, which is highly sensitive in detecting acute bleeding. And in the initial stage itself, we can identify. The next thing is CT angiography or MRI angiography, which identifies the source of bleeding such as an aneurysm or not. So in normal non-contrast CT, it will give you the idea that there is a bleeding, but if you want to properly identify the bleeding is happening in which area, you have to go for either CT angiography or MRI angiography. So this will give more idea about the source of bleeding. And the third one is digital subtraction angiography or DSA. So this is the gold standard for detecting vascular abnormalities, especially vessel-related abnormalities. So in case of subarachnoid hemorrhage, we can see that 85% of the cases are mild to severe, belongs to the aneurysms, that is the breakage of small blood vessels. And non-aneurysal perimencephalic hemorrhages are 10%, and some miscellaneous cases are AVM, vasculitis, reversible cerebral vasoconstriction syndrome, that is RCVS. We will see in the upcoming slide what is RCVS. So the interpretation is that most SH causes arise from a ruptured aneurysm. The main cause behind this hemorrhage will be aneurysm because 85% of the cases are by means of aneurysms. That is the wall thinning or the balloon formation in the artery wall. So these non-aneurysmal hemorrhages are rare causes account for the remainder. But identifying the cause guides the treatment strategies because if you go with a subarachnoid hemorrhage, the doctor need to identify what is the exact cause for that, whether it is an aneurysm based or it's a AVM based or it's a due to RCBS. He need to identify that one. Then only he can make a remedy. So the source of cause need to be identified first. That is the important thing. So now we will see what is aneurysm. So, as a definition, aneurysm is an abnormal bulging or dilation in the wall of blood vessel. This is often due to weakness in the vessel wall. So, when the age increases, this may happen in persons with age above 60 or 65. Initially, it will start. If it is going to 75, 70, 80, it may increase. So, the types are cerebral aneurysm. It is common in the brain, especially in the circle of Willis. And aortic aneurysm, it is occurs in the aorta, including the abdominal and thoracic regions. And peripheral aneurysms there, it can occur in arteries like the femoral or polyteal. And prevalence is aneurysm are relatively common with cerebral aneurysm affecting 2 to 5% of the population. So it is there in some people. In the total population, 2 to 5% of the people are affected with these small kind of aneurysms. So in this case of aneurysm, we can use CT angiography because as I told earlier, we need to find the cause, exact cause. So for that, we need to see the vessel information, whether the wall thinning happened or not, any bulging is there or not. So for that, we need to use the CT angiography. So this is giving around a 93% accuracy. I feel like it's a good accuracy. And it provides a detailed axial, sagittal, and coronal images. So we will get a 3D image. So you can project it to either axial, sagittal, or coronal planes. So the doctor can analyze a 360-degree view. So he can identify exact volume of the balloon formed or the thickness of the walls, etc. So the common sites are anterior or posterior communicating arteries or middle cerebral artery. So these are the main arteries which may affect with aneurysms. And CTA is the gold standard for non-invasive aneurysm detection, offering a detailed visualization to aid diagnosis and surgical planning. And when you come to the aneurysm, the causes are different factors are there. The first thing is the genetic factor. Genetic factor means the family history, connective tissue disorder. For example, Marfan syndrome is there. So this is due to the connective tissue disorder. And second is the hypertension. It may be due to the high blood pressure that can increase the risk of vessel wall thickening. That is the second point. And the third one is the atherosclerosis. That is the hardening of arteries can lead to aneurysm formation. The arteries will be hardened due to the aging. And next means infections or trauma. So infections or trauma can weaken vessel walls and contribute to aneurysm development. So the risk factors are smoking, high cholesterol, advanced age, and drug abuse. Let's say, for example, the use of cocaine or any other such kind of substances. So when we talk about this atherosclerosis, it is hardening of arteries. Like this is actually happened mainly due to smoking or high cholesterol. So this may happen. And if you look at here, this is an aneurysm in the right middle cerebral artery, that is RTMCA aneurysm. It is the right middle cerebral artery. So this is the CT image along with the angiogram. So this angiography shows the structure of the vessels within this right middle cerebral artery. So from this, we can easily identify the narrowing of the blood vessels and the thickness, if any balloons kind of things formed, we can easily identify. So this is the advantage of taking a angiogram, CT angiogram in case of aneurysm. So next is the another angiography image of two cases. The first one is anterior and the second one is the peripheral. So if you see two images are there, these are showing multiple aneurysms. So multiple aneurysms, here you can see that these regions were narrowed. These dark regions were narrowed. Balloon formation, you can see here. This is the anterior segment and this is the posterior segment. So these are the two images for anterior and posterior cases with multiple aneurysms. Here you can see that lot of aneurysms. So the symptoms are unruptured aneurysms are there. Unruptured means it is asymptomatic or the causes are very subtle symptoms. We cannot easily identify. It may be a simple headache or vision disturbance. So in this case, there is no rupture, simply a unruptured aneurysm, and it is asymptomatic. But in case of ruptured aneurysms, there will be a sudden severe headache, nausea, vomiting, or neurological deficits. Let's say, for example, some people suddenly go paralyzed, or some people may lose vision. So these kind of things are the outcome of a ruptured aneurysm. That means it is very symptomatic. And complications are subarachnoid hemorrhage. The main thing is subarachnoid hemorrhage. And the rupture of a cerebral aneurysm can lead to life-threatening bleeding of the brain. So if aneurysm is there and if it is a ruptured aneurysm, definitely it will be go to a subarachnoid hemorrhage. And that will be a life-threatening situation for the person. And last one is aortic dissection. So rupture of an aortic aneurysm can lead to massive internal bleeding and death. So this is another point. So now we have to see AVM. So we already seen AVM and IPH earlier. So AVM is a congenital vascular abnormality where the abnormal connections form between arteries and veins bypassing capillary. So as you know, we have artery is there, vein is there, capillary is there. Three set of veins are there. Okay, so in case of AVM, it's a congenital vascular abnormality where the abnormal connections form between arteries and veins bypassing a capillary. Actually, it should go through the capillary, but the capillaries were bypassed and the connections will be directly taken from artery to vein. Okay, so in such cases, the AVM happens. And in second case, IPH, that is intrapharyngeal hemorrhage, that is a cerebral hemorrhage, intracerebral hemorrhage, and SH, that is the subarachnoid hemorrhage. AVM can lead to both cases. In aneurysm, we can see that aneurysm will lead to subarachnoid hemorrhage. But in case of AVM, AVM can lead to both intrapharyngeal hemorrhage or subarachnoid hemorrhage due to ruptured vessel. Okay. So why this happens? Because it is related to vessel. That's why it may go either to SAH or IPH. So prevalence is AVMs are rare, but ruptures can cause severe neurological consequences. But AVMs are very rare compared to IPH. So here you can see that IPH plus SAH due to AVM. So these are the sample images for this IPS plus SAH due to AVM. So this is actually the IPH and this is SAH and this is a combination of both. So when we talk about the subarachnoid hemorrhage, so we can see that the mechanism is mainly the rupture of AVM vessel. So now we are going to see the differentiation between the subarachnoid and the intracerebral. Okay. So in first case, for the rupture of AVM vessels, this is the mechanism behind subarachnoid. Okay. So AVM. The rupture of AVM vessel happens when the blood flow in the AVM is high pressure, causing vessels to weaken and rupture, leading to hemorrhage. So when pressure increases, the vessels will be broken and bleeding will happen. Okay. So in IPH case, that is intracerebral or intrapharenchimal hemorrhage, the bleeding occurs within the brain or the parenchyma tissue, leading to neurological deficits. Okay. So in SIH, the blood spills into the subarachnoid space, potentially causing irritation and inflammation of the brain, along with increased intracranial pressure. So this is the first one is the IPH and second one is the SIH due to AVM. So we just seen RCVS earlier. This is one of another cause for subarachnoidal hemorrhage. So RCVS is nothing but reversible cerebral vasoconstriction syndrome. So the symptoms are severe headache, nausea, vomiting, altered mental status, and focal neurological deficits. We can diagnose it with the help of a CT scan. First choice to detect SAH and hemorrhage location. Then we have to use MRI and angiography, CT angio or MRI angio or digital angiography to identify the underlying cause. So initial screening tool will be the non-contrast CT followed by the angiography so that we are able to identify the exact cause. So this is some example of SH due to cortical vein thrombosis. So here you can see that the veins are connected through the outer layer. So here you can see. So this is due to the vein thrombosis. Here you can see the ruptures in the vessels. Here also you can see. These are subarachnoidal hemorrhage due to vessel vein thrombosis, cortical vein thrombosis. So next one is the perimesencephalic non-aneurysmal subarachnoid hemorrhage or PNSH. So this is another kind of subarachnoid hemorrhage. Just a minute, I'm taking some water. Okay. This is a distinct type of SIH, that is subarachnoid hemorrhage. It is characterized by a bleeding localized around the midbrain region without evidence of any aneurysm or imaging studies. So here if you see, you cannot identify any vessel breakage or aneurysms. Okay. So it is a non-aneurysmal in origin. That is, it may be often attributed to venous bleeding, through the exact source is usually not identified. If you look at here, we can see that some regions having some hemorrhage, but we are unable to identify the exact cause behind this. Why? Because it is non-aneurysmal cause. So in this case, 10% of all SH may comes under this PNSH, and it is around the pons or midbrains. And CT angiography shows negative. Probably venous bleeding will be there. The veins will bleed. And benign outcome is not rebleed or ischemia. It will be once happens, there will not be any rebleeding or ischemia. So that is the thing. And generally it will be happens only in 10% of all SIH. And now we are going to see the complications of subarachnoid hemorrhage. So hydrocephalus, that is the first one. That is the excess cerebral spinal fluid or CSF causing increased intracranial pressure. Okay. So when the blood is leaked, it is mixing up with the CSF. So increased volume of fluid there, so which causes increased intracranial pressure. This is one complication. Second thing is the rebleed, reoccurrence of or recurrence of bleeding after initial hemorrhage. So initially maybe some veins may be broken, again some other veins broke, there will be a rebleeding. Okay. That time also the volume increases, that may lead to increased pressure. Then vasospasm or ischemia, that means blood vessel narrowing happens or reducing the cerebral blood flow post hemorrhage, because most of the blood is flowed into the CSF and there will be less blood to flow through the other parts of the brain. So this also be a complication. And second thing, the initial CT here you can see. Here you can see an 8 years after CT. So here you can see that ruptured left MC aneurysm. This is the cause. Left ruptured LT-MC aneurysm happened here. So here the problem is hydrocephalus complication. That means increased intracranial pressure. The impact is it's a cognitive decline. That means vision issues, altered consciousness. People may go unconscious. Then rebleed complications. Initially you can see that the bleeding is very less here. Okay, after 8 hours you can see the bleeding is increased to all the other parts. Okay, the impact is worsened neurological outcomes, high mortality risk. Similarly, then vasospasm or ischemia complication, reduced cerebral blood flow, and impact is delayed ischemia or permanent brain damage, or it will further lead to stroke. So this is the complications of SH. And in case of hydrocephalus, regular monitoring of intracranial pressure is required. Okay. So early imaging using CT or MRI to detect the CFS accumulation. Then timely intervention with shunts or external drainage system. Sometimes it may be taken out to control the volume inside the brain. And second thing, in rebleeding, a strict blood pressure management is required for controlling the rebleeding. As you know, if the pressure increases, if any wound is there, there will be a chance of bleeding very fast. So we need to control the pressure. So we need to go for a pressure management. And then use of antifibrinolysis in high-risk cases. And also use early surgical clipping or endovascular coiling of aneurysms we need to do to avoid the rebleeding. And in case of vasospasm or ischemia, prophylactic administration of nimodipine need to be given, or maintaining the evolmia with proper hydration and continuous neurological monitoring of early detection. So main thing is first you have to go for the normal CT scan, then followed by the angiogram, or angiogram will give you the details about the vessel which having narrow or which is broken, so that you can exactly identify the cause and you can give the remedy in a proper time. And also we need to analyze it for a long time to see is there any rebleeding or any ischemia is happening. So next we are moving to the intraparenchymal hemorrhage. That means the intracerebral hemorrhage. It comes under intracerebral hemorrhage. So in this case, the radiologist's role is to find out the cause include hypertension, amyloid angiopathy, vascular abnormalities or neoplasm, and coagulopathy. And IPH has diverse causes. Radiologic imaging is pivotal for classification and its management. So symptoms are sudden onset of headache. Headache will come. Then neurological deficits, that is weakens, slurred speech, vision changes. And the third point is the nausea, vomiting, and decreased consciousness in severe cases. And the signs are hemiparesis or hemiplegia. Or gaze deviation, aphasia or dysarthria. So hemiplegia means it's a condition that means a complete paralysis of one side of body. I think you heard about sometimes suddenly some people paralyzed and only one side is paralyzed. Okay, that is hemiplegia. And next thing is gaze deviation. So gaze deviation means it is an inability to move both eyes in a specific direction. In general, we can move our eyes in both way, right? But if this happens, we are unable to move both eyes in a single direction. That is the problem. And the third one is aphasia. Aphasia means it's a language disorder. That means the if some damage happened to the brain, which affects the ability to speak, understand, or read or write. Okay, so it is typically associated with injury of the left hemisphere. Okay, if something happened to the injury happened to the left hemisphere, he will be unable to talk properly. That is the main problem. And the last one is dysarthria. Dysarthria. So dysarthria means it is a speech disorder caused by paralysis. Okay, as I told earlier, if hemiplegia happened, that may lead to paralysis of one side, right? Because of that, the mouth, one side of mouth may be go in different shape. So in that case, you are unable to speak. So that condition is known as dysarthria. So these are the signs and signs of elevated ICP. That is uh, papilledema or bradycardia. So these are another problem. And severity, it depends on the hemorrhage location and volume. So we cannot say that initially it may be a very big issue, but depend upon the hemorrhage location and volume, it may change. Okay. So, and the bradycardia is nothing but it's a condition where the heart rate is lower than normal. I think you heard about the during our sleep, sometimes the heartbeat may go beyond 60. So that is known as bradycardia. That is the heart rate may be going beyond 60. In certain individual, it may be normal, but in some disease case, it may go till 52 like that. Next is the imaging studies. CT scan, as I told earlier, non-contrast CT, it is the gold standard for detecting acute bleeding. And MRI, it is useful for identifying the underlying causes. So you may have a doubt that why you are using CT and MRI. Why? Because in non-contrast CT, it will initially tell there is an acute bleeding or not. But MRI will tell you where the exact location. So it will give more details about the soft tissues. Okay. So then laboratory tests are there. That is coagulation profile or rule out coagulopathies are there. There are some laboratory tests available. Then blood pressure monitoring to assess the hypertensive crisis. Then differential diagnosis. That means ischemic stroke or again SIH, brain tumor or encephalitis. So the initial management. So if you look at this picture, you can see that acute. This is the acute case where more hemorrhages happened. So in the initial management, stabilize airway, breathing, and circulation. This is ABC, the first thing. And second thing, blood pressure control. So example, IV can be given to reduce the blood pressure and monitor and manage ICP. That is head elevation, hypertonic saline. This can be given to manage the ICP. Then surgical intervention indicated for large hematomas causing significant mass effect. And options include craniotomy or minimally invasive hematoma evacuation. So then the supportive care we have to give. So the Craniotomy is nothing but it's a surgical procedure which a portion of the skull is temporarily removed to allow access to brain. Suddenly they will remove the skull part and access to the brain, and it is performed to treat various brain conditions including, say for example, trauma or tumors or hemorrhages or any other neurological diseases. Okay. And it may be done on an emergency basis if the person is having a trauma or tumor or aneurysm or even an infection or epilepsy. So in case of epilepsy, we need to remove the epileptic foci causing seizure. So for that also this process may be useful. And the last one is the supportive care. That is for anti-convulsants or seizure prevention and physical and speech therapy for rehabilitation. See, after the person is paralyzed, the medicines will be given to recover, and we need to give rehabilitation therapy to make him speak properly. So we need to give the supportive care. And second thing is the prevention strategy. Primary thing is to strict blood pressure control. You have to control the blood pressure in a proper way. And smoking cessation and reduction of alcohol intake. So definitely you have to reduce the amount of smoking and alcohol intake. Secondary thing, anticoagulant management in high risk patients. Sometimes the doctors may give anticoagulants to the patients, and regular screening for vascular abnormalities. Let's say, for example, normal angiography you can take and analyze whether the vessels are in normal stage or not. And if you look at this picture, you can see that this is an acute case and this is a chronic case. Chronic case means here you can see that the hemorrhage is much increased. So the prognosis, it depends on the size and location of the hematoma and the patient's overall health. And early intervention improves survival and functional recovery. And mortality rate is 40 to 50 within the first 30 days of severe cases. So if you find in the initial stage itself, you can easily identify and you can make it more correctable using medicines. And the etiology means the hypertension, the reasons, amyloid angiography, then vascular, that means AVM or CAV hemangioma, and neoplastic, that means GBM or metastasis. And the last one is the coagulopathy. Then hypertensive hemorrhage are there. So in hypertensive hemorrhage, the diagnosis is done by using CT or MRI. So it detects the hemorrhage and evaluates its size and impact on surrounding tissue. Management is like blood pressure management to control the hypertension, the surgical intervention for large hemorrhages with significant mass effect on neurological deterioration, and supportive care to manage neurological symptoms and recovery. And it is common in basal ganglia. So this intracerebral hemorrhage. And or in thalamus or pons and cerebellum. So this basal ganglia is nothing but a group of interconnected subcortical structures in the brain, which is responsible for regulating motor control. I think you heard about motor veins, right? So the same thing is this basal ganglia. So in case of our eye, the ganglion cells are connected with this basal ganglia. So that provides us the vision. And it may also happen in the thalamus or in the cerebellum or in pons. And the chronic hypertension weakens these blood vessels and leading to rupture in deep brain structures. As I told earlier, the hypertension is one of the main cause. And this imaging typically reveals hematoma locations associated with the hypertension. If you take either CT or MRI, you will be able to find this. And pons means it's actually a part of the brain stream located between the midbrain and medulla oblongata. So in between the midbrain and medulla oblongata, there will be a portion that is known as the pons. Okay. So this is actually a critical role in relaying information between various parts of the brain, including the cerebral cortex and the cerebellum. So our vision is mainly happen due to cerebral cortex. Okay. So this cerebral cortex is contained in the pons site. And next is the amyloid angiography. So in amyloid angiopathy, so recurrent spontaneous lobar hemorrhages will happen and progressive cognitive decline. That means the cognitive decline will be a progressive manner in severe cases. And neurological symptoms related to the location of hemorrhage, that is motor deficits, seizures, or visual disturbances. And signs are transient neurological episodes, including sensory or motor disturbances. Then microbleeds detected on imaging before large hemorrhages occur. So in this amyloid angiopathy, you can see that this is the initial one, and third month, 3 months later, you can see that here also it is affected. And next one is AVM. We already seen AVM. So AVM is the bleeding from the nidus or the proximal portion of the draining veins. And it may be the causes for, we already seen that parenchymal or intraventricular SAH. And we can use the same CT angiography for detecting this. So AVM is nothing but the atriovenous malfunction. Okay. And if you see the AVM of a 12-year boy, so you can see that the atriovenous malfunction, it's an abnormal connection between the arteries and veins. I told earlier by bypassing the capillary system. Okay. So most commonly occurs in the brain and spinal cord, but can affect any organ. So here, this can affect any organ, not only brain. Okay. And AVMs are but rare, with an estimated prevalence of 1 in 1 lakh individuals. And this can lead to significant complications, including hemorrhages, seizures, or any neurological deficits due to this AVM. This is actually 12-year boy's AVM image. And the causes for this intraparenchymal hemorrhage are congenital. That means AVMs are often present in birth due to abnormal vascular development during embryogenesis. So during the formation of embryo, the vessels and all the other vascular development will happen. So that time, the arteries are not connected through capillaries to vein due to congenital issues. This may cause intraparenchymal hemorrhage. And acquired, sometimes it may acquire. In some rare cases, AVMs may develop later in life due to trauma, infection, or any other vascular condition. So there are two main causes, either congenital or acquired. And in next is intraventricular hemorrhage. In intraventricular hemorrhage, as you see here, it is happening inside the ventricle. Okay. So it is bleeding into the brain's ventricular system, which contains CSF, and IVH can occur as an isolated condition or as an extension of other type of intracranial hemorrhage. It not only happen as alone, it can be an extension of the other hemorrhage, such as a subarachnoid or intrapharyngeal hemorrhage. There are two types. First one is primary IVH, and the second one is secondary. In primary, we can see that bleeding originates directly within the ventricular system here itself, and rare cases often associated with vascular malfunctions or tumors. And secondary, bleeding extends into ventricles from other types of hemorrhages. Say, for example, if it is happens here nearby ventricle, it may go inside. That is intracerebral or subarachnoid hemorrhage, and more common type than primary IVH, because if the hemorrhage happened which is subarachnoid or intracerebral, which is severe, that may be lead to the ventricle side, so that may cause IVH. So the causes are mainly neonatal IVH is there, adult IVH is there. So in neonatal case, that means for small kids, that is neonatal means less than 28 days, immature blood vessels in the germinal matrix, or and the risk factors are prematurity, less than 32 weeks gestation. if the baby is delivered less than 32 weeks gestation period, a low birth weight may be there, hypoxia or ischemia or mechanical ventilation or fluctuating blood pressure. So these are the chances of neonatal IVH. And when it is coming to the adult IVH, definitely trauma, that is severe head injuries, hypertension, that is rupture of deep-seated vessels, then AVMs, as I told earlier, AVMs, bleeding from ruptured cerebral blood vessel, then tumors, vascular tumors like glioblastomas or metastasis. And coagulopathies, that is blood clotting disorders or anticoagulant use. In metastasis, it is actually spread of cancer cells. So if tumor is there and tumor is cancerous, okay, then that may spread to the nearby tissues. And then finally the infection, rarely meningitis. I think you have heard about meningitis. It is an infection happens in the brain. The meningitis or abscesses. Abscesses means pus in the brain. Pus in the brain. So these are the causes in IVH in adult. So intraventricular hemorrhage symptoms depend on the volume of blood, ventricular involvement, and associated intracranial pressure of ICP. So in acute IVH, sudden severe headache, nausea and vomiting, altered mental status, that is drowsiness, confusion, or coma, then seizure and hypertension. And in neonatal IVH, apnea or irregular breathing, then bulging fontanelli, seizures. Seizures means actually a sudden or uncontrolled electrical disturbance in the brain, which can cause changes in behavior or movements or sensations or consciousness. So this is actually seizure. And then for in case of neonatal, we have weakness or limbness is there. Then poor feeding. The kid may not take proper feeding. So another cause. And the next hemorrhage is subdural hemorrhage. Okay. In subdural hemorrhage, here you can see that these are the regions where this hemorrhage happens. So this bleeding occurs between the dura mater and the arachnoid mater. So these are the dura mater and arachnoid mater. In between it is happening. So it is common in elderly individual or those on anticoagulants. So types of subdural hemorrhages are acute subdural hemorrhage. So develops rapidly after severe head trauma. Okay. And high mortality rate due to rapid mass effect of the brain. Next is subacute subdural hemorrhage. Symptoms appears days to weeks after the injury and represents the transition between acute and chronic. And the third one is chronic subdural hemorrhage. Develops over weeks to months, often in older adults or those with minor trauma, and may present with subtle neurological symptoms. And the main causes are, the first thing is trauma. As I told earlier, the trauma will be first reason. And the most common cause, particularly in high impact injuries, that means falls or accidents. And next is the coagulopathy, that means anticoagulant or antiplatelet use. For example, warfarin or aspirin usage. And last one is, the third one is alcoholism, that is chronic alcohol use weakens blood vessels and lead to head trauma. Then brain atrophy. So brain atrophy in elderly individuals, brain shrinkage stretches bridging veins, making them much vulnerable. The fifth one is shaken baby syndrome. In infants, due to shaking force causes rupture of veins. I think some people will take the kids and suddenly throw it to the sky and then catch it again. So generally people will say don't do like that, because in infants and all, due to this shaking, this force causes a rupture of veins that may lead to subdural hemorrhage. And the symptoms in acute case are severe headache, rapid worsening, neurological deficit, that is weakness or numbness, loss of consciousness or going to coma, seizures and increased ICP, that is ICP. And in chronic case, gradual onset of symptoms over days or weeks, persistent headaches, cognitive changes, that is confusion, memory problem. And the next is the mild focal neurological deficits and guide disturbances in some cases, unable to move, some problem with walking or something like that. And the last one is epidural hemorrhage. In epidural hemorrhage, it is also called as epidural hematoma. It is a collection of blood between the dura mater, that means the tough outer membrane of the brain. This is the dura mater, and the inner surface of the skull. This one, and this one. So this is the sample image which shows the epidural hemorrhage, and it is often associated with the head trauma and is a neurosurgical emergency requiring prompt intervention. And the main causes are trauma, that means a fall or accident, the most common cause, particularly from skull fractures, and that damages the middle meningeal artery or its branches. And the common scenarios includes falls, motor vehicle accidents, or sports injuries. And non-traumatic causes are rarely spontaneous EDH can cause occur due to coagulopathies or vascular malformations or infections. Okay, so EDH is nothing but the epidural hemorrhage, epidural hemorrhage. The short form is EDH. And the symptoms are depends on the size, location, and speed of bleeding. The landmark presentation is a lucid interval. That means a temporary improvement in consciousness followed by rapid deterioration. The initial symptoms are minutes to hour after injury, loss of consciousness immediately after trauma, and a period of lucidity that is present in about 20 to 30% of cases. Then progressive symptoms like severe headache, nausea, vomiting, confusion of drowsiness, weakness or paralysis on one side of the body, and dilated pupil on the side of the hemorrhage, and seizures. And this dilated pupil on the side of hemorrhage due to compression of the oculomotor nerve. And severe complications, signs of brain herniation, that means the compression of brain structure leads to irreversible damage, that means a bradycardia or hypertension. So with this, I close the basic explanation regarding the types of intracranial hemorrhage. Now I am moving to the some of the works which done on this intracranial hemorrhage classification. So in this, first one is machine learning based classification of spontaneous intracranial hemorrhage using a radiomic feature. So in this case, as an introduction, the purpose is to assess the efficacy of radiomic features extracted from non-contrasted computer tomography scans in differentiating multiple etiologies of spontaneous ICH. Okay. So as we know, the ICH is a prevalent subtype of stroke with a high mortality and morbidity rates. And the radiomics enables the extraction of quantitative image features, improving the diagnostic precision. And radiomic features help classify ICH into primary, tumor, and vascular causes. So we can divide it into three categories. So now the data set used in the work is taken from Maharaj Nakhon Chiakmi Hospital. It is sample size of 141. NCCT scans obtained during the time 2020-22. And the clinical features are age, gender, and ICH location. And excluded data, poor image quality, and unrelated etiology. Some of the images they have removed. Okay. So the radiomic features here they have taken are like the shape feature, like volume, surface area, compactness, uh, sphericity, elongation, etc. And the intensity parameters, that means the first order parameters like mean intensity, standard deviation, skewness, kurtosis, entropy, etc. And the texture features, it may be the GLCM or gradable size zone metrics. Then we can say that wavelet features or higher order features like the Laplacian or Gaussian features we can consider. So here what they taken 1 to 141 patient data, and primary ICH are 57 and tumors are 46 and vascular malfunctions are 38. So these are the three categories they have taken. They have considered this data and they segmented the masks, and they taken the original image in 3D and they have taken first order features, around 36 features they have taken. Then shape based intensity features are 36, then shape based features are 28, and textural features they have taken 1650 features, and 150 from original and 1500 from filtered image. And then they have applied some machine learning uh, algorithms, and before that they given it to combined all the features together to form 1714 features, and they passed it through mutual information and selected feature from the first hierarchy. That means they have done a feature ranking. From the feature ranking they have selected 7 features from hematomas, and 7 features from edema regions, and 5 features from hemorrhage region, and 5 features from second hierarchy. So 2 hierarchy they have mentioned, 7 features each from the first hierarchy and 5 features from the second hierarchy. And is there any tumor cases they have decided as tumorous? Second case non-tumorous. Then that will also coming to the primary related ICH. There they have classified it as primary ICH or a vascular malfunction. So this is the workflow. And the methodology, they have collected the data from the data set which I mentioned earlier. They have done the feature extraction using pyradiomics, and the features categorized into first order shape based and textural matrices. And feature selection they have done with a mutual information method, and they have first classified it as a tumor or non-tumor, and second classification they have done it as a primary or versus vascular causes. And the tested classifiers are adaptive boosting or adaboost or random forest and logistic regression. So this is actually simple machine learning methodology. The models they are evaluated using accuracy, sensitivity, and specificity matrices, and these are the features they have used, and the tools they have used 3D slices and slicer, and for image segmentation, and radiomics for extracting the feature. And the results they have shown here. For the primary case, 49 out of 58 were correctly classified, and sensitivity for a primary is 86, tumor 78, and vascular 72. Specificity of primary is 78, tumor of 93, and vascular for 83%. So advantage of their the work is high performance and robust feature selection and real world applicability and enhanced diagnostic aid. And the next work is detection of intracranial hemorrhage by artificial intelligence and deep learning methods. So here, the traditional methods rely on manual interpretation of CT images, right? So in previous method, we see that they have used 3D slicer to extract the segmented part, and then they are extracting the feature using pyradiomics software and doing the machine learning classifier. If the amount of data set is less, it is fine. But if you have more number of images or data, we have to definitely go for neural networks for deep learning. So in this case, the data set is RSNA dataset, that is 2019 brain CT dataset, which is having the 5 categories. That is, the epidural image is there, intrapharyngeal image is there, intraventricular hemorrhage is there, subarachnoid hemorrhage is there, subdural hemorrhage is there. Okay, all the 5 categories are available. It is having around 8,74,000 images belonging to each category. Okay, that means around 498 GB of image of these 5 categories. It's a huge data set. So that's why they done a deep learning methodology. And first thing they have done the data set preparation. So they removed the duplicate images Then class balancing using data augmentation, rotation, scaling, and brightness. As you know, if you have more number of images, in case of deep learning, we have to go for almost equal number of data set in each category. Otherwise, bias will happen towards the more dominating category. So you can either use class balancing by means of data augmentation, or you can use the methodologies like optimization methodologies like SMOT or ADASINs. So you can use SMOT or ADASIN methodology to make sure that the data are balanced. SMOT is nothing but synthetic minority oversampling technique. So this will oversample the other undersampled data and make sure that all data having equal number of data samples in the each category. So here what they have done, they have taken different pre-trained networks like exception, and exception is worked well, and it uses depth-wise separable convolution to reduce the computational complexity. And similarly, they have tried other pre-trained networks like ResNet, EfficientNet, VGE16, Inception, and MobileNet V2. And model interpretation they have done with GradCam. That means visualizing the cortical regions used by the network for classification. So this GradCam image will give more interpretation about the how the CNN will identify these regions. So how we obtain the GradCam is that we will take the penultimate stage of layer of the CNN, and that will be placed on the original image so that we will get a GradCam image. So this GradCam image will tell you in which region this disease is affected, so that we are easily able to identify using a GradCam visualization where the disease is affected. So in their work, final quality metrics for each neural network is mentioned here. So in case of exception network, they have obtained around an accuracy of 95.18% and an AUC of 96.39 and a loss of around 0.0839. So exception, the out of all these pre-trained networks, exception given the best result with a 95% of accuracy in all the 5 categories. And so these are the performance metrics for this particular work. And advantage is it is an advanced neural network, but interpretability is obtained by means of a GradCam visualization. And it is using, since it is using an exception, it is efficient in processing with the computational complexity less compared to the other state-of-art pre-trained networks. And broad application, here we have considered 5 hemorrhages. Okay, so 5 type of hemorrhages we have considered. So this network is more generalized in terms of the all the ICH. And third one is the deep learning tool for early identifying non-traumatic intracranial hemorrhage etiology based on CT scan. So this study developed an AI system to identify the etiology of non-traumatic ICH using again a non-contrast CT image. The objective was to improve diagnostic accuracy and to support clinical decision. So the development data set, they have around 1868 NC CT scan classified into aneurysm, hypertension, AVM, MMD, and other etiologies. Total processed 33624 NCCT volume, and they have obtained this much scans. So here, if you look at these images, here the images are mainly the cause of the ICH, not the ICH type. Okay, causes like aneurysm, hypertension, AVMs, or MMD. So here the testing data set is 200 scans. That is aneurysm 35%, and SD 98, that is 98 scans of hypertension. And in methodology, they have proposed a net called ICH net CNN, inspired by slow fast network specifically designed to manage the temporal and spatial complexities of 3D NCCT scans. So when you consider the 2D image, you are only getting the spatial complexities. Okay. So when you consider 3D, you will get both temporal and spatial information. So temporal means each slice-wise information you will give. Let's say, for example, if you have an image with 30 slices, you will get each temporal information, time information, each slices. So this architecture prioritizes high sensitivity for identifying etiologies such as aneurysms and hypertensive hemorrhages. And for pre-processing, as we know, we need to remove the skull by using skull stripping. And we need to normalize, the intensity normalization needs to be done, because each image are taken from different machineries and that may have different intensity. So we need to normalize the intensity into a standard value, and then training the details using the proposed network. The evaluation, since they are having only less number of images and there is a large data imbalance, they have done with the five-fold cross-validation. So in this five-fold cross-validation, all the data set will be divided into 5 categories, 5 folds, and 4 fold will be used for one-time training, and the 5th one will be used for testing. And again, after that, the tested data will be given back to the training set, and one training data will be taken from training set and used for testing. And this process repeats 5 times, and we will take the average of all the results. If you have a less number of images or data imbalance in the image, you have to go for cross-validation. So here, there are 2 networks. One is the first path and second one is another path. So after pre-processing, this data set is passing through each path, and we are concatenating these results, features, and after global average pooling, then we are giving it to the normal MLP or DNN for predictions. So these are the predictions we are having here. So as a result, we are getting different CNNs, and we take all the results and we do the cross-validation, and we are getting the ensemble model. Here, why we call it as ensemble model? Because we are taking 2 different methodologies. First one, DCNN, and second DCNN. And we are adding or averaging the result of these 2. That's why we call it as an ensemble model. And in this case, this TT200 data set, it is providing a result of aneurysm as 0.986 or 98.6%, hypertension of 95.2%, and AVM of 95%. And on SD98 data set, aneurysms of 94.5 and hypertension of 88.3. So it enhances diagnostic precision and provides robust decision support for clinicians. And here, since we have only less number of data, the results are as an outcome of 5-fold cross-validation with an ensemble model. So these are the sensitivity curve for all different categories, sensitivity versus specificity curve. That is the ROC curve. And these are the classification results. And the last one is the radiomics and deep features. It's a robust classification of brain hemorrhages and reproducibility analysis using a 3D autoencoder neural network. So here it combines radiomic and deep learning features to classify brain hemorrhages with high reproducibility. That means a combination of machine learning plus deep learning. So it aims to bridge the gap in diagnostic consistency and accuracy. And a multi-center data set of 720 CT scans ranging from 2016 to 22 with the following distributions have been taken: SDH of 16%, EDH 8%, CC 25%, SAH 16.6%, and IPH 28%, and IPH 12.5%. And each scan is occurred with a 64-channel CT scanner slice thickness of predominantly 5 mm. And these are the visualizations of manual segmentation for hemorrhages types, including CC, EDH, IPH, IVH, SH, and SDH, labeled from A to F. So these are the manual labels obtained for these hemorrhage regions from a specialized radiologist. And the methodology is the radiomic features. For that, they have extracted 215 features using a software Sera. And deep features, DF extracted 3D autoencoder. So here they have used 3D CNN as a 3D autoencoder for extracting the spatial encoding, spatial features. And this encoder uses a multiple of 3x3 convolutions, 3x3 convolutions to transform the input CT image into data representations. And decoder, which mirrors the encoder with the upscaling layers. So encoding side, we are doing downsampling, and the decoding side, we are going to do the upsampling. And for the binary cross entropy loss function minimized with the Adam optimizer, they have used, and the hyperparameter train tuning for model optimization. And evaluation they have done with the classifiers like SCM and radon forest. Matrices they have used this AUC sensitivity and F1 score. So this is the data collection, image pre-processing. They have brain hemorrhages are segmented, then feature extraction, then the classification. So here, similarly, the autoencoder, decoder, then we taken the feature and given for classification. So results for radiomic features, AUC up to 8.9. And for deep features, you can see that AUC is increased to 0.96 and accuracy 0.93. So it improves diagnostic accuracy and the feature reproducibility essential for clinical application. So when you consider the radio features, you can see that only AUC of 89%, right? But when you go for deep features with the 3D CNN, you can see that AUC is increased. Why? Because in radiomic features, we are only taking the features by manually, but in deep features, we are extracting features from the 3D structure. So we will get more information from the sagittal, coronal, and the axial domain, so planes. So it will be much better compared to the radiomic features. So with this, I wind up the session. If you have any queries or questions, you can ask.
Thank you, sir. The forum is open for discussion. If you have any clarification, participants can ask. Either type in the chat window or you can unmute and ask. Sir, the data sets, whatever you have mentioned, is it a public data set, sir, other than
Yes, yes, all are publicly available data sets.
Yes, okay, sir. All are CT image data sets, right?
Yes, CT images, yes. All are non-contrast CT.
Non-contrast CT.
Yes, yes. These are the initial stage. So detailed stages are not much available because most of them are finding it using angiogram, right? So those are not much available. Mainly, we need to identify whether hemorrhage is there or not, and its category. For that, NC is not NCCT is available.
Okay. So there is a question in the chat window. Are you using any tool for extracting radio?
We can use a Pi Radio Mix or one more software is there. That is, I think, Sera, SERA. Pi Radio Mix or Sera, SERA. These are the two softwares you can use for extracting radiomic features. Computational system means if you going to use a deep learning kind of applications, you can go with the latest AMD processor, Threadripper Ryzen processor with graphics card of minimum 24 GB GPU. Latest, I mean, GeForce, NVIDIA GeForce 24 GB or 48 GB GPUs you can go for. If it is a 24 GB, it may comes around 6.5 lakhs, and if it is 48, it may go up to 8 or 9 lakhs for the whole system.
Sir, am I audible, sir?
Yes, yes.
Sir, I have one doubt.
Yes.
For detecting CT scan images and all, we are using this technology. Is any biomarker is possible, sir, to detect brain tumor and all like that?
In which area you are working?
Brain tumor detection, sir. Image processing.
Which image you are using?
Brain tumor, sir. Brain tumor images.
No.
Whether it is
Is it
CT or
possible,
MRI?
sir? We can implement it as like biomarker. It is a separate field. We can use. Is it possible, sir? We can by using biomarker we can detect tumor and all.
Yes, I see. The main thing is for. Are you able to hear? Yeah.
Yes, sir.
So the
Yes, sir.
main thing is in case of tumor and all the MRI will be much better, because if you consider T1 or T2,
Oh, yes,
there
sir.
will be different scans like T1, T2, FLAIR, and GRE, DWI, all those schemes are there. Okay. So in FLAIR, the tumor will be much visible. So basically, we try with a tumor with MRI. So here,
MRI.
intracranial hemorrhage, we are going to try with NC-CT, because it is the gold standard for detecting the hemorrhage. But when you
Okay.
go for brain tumor, you can try like isocitrate dehydrogenase, that is IDH mutation. Okay, it can be found in low grade gliomas. That means the presence of IDH mutation. This is one of the biomarker. Okay,
Okay, sir. Okay, sir.
this is
Thank
one of the
you.
biomarker for brain tumor. And second thing, another parameters like we can see that the measurement of the blood flow and cerebral spinal fluid CSF, and the volume measurement also we can do for the tissue. That means for the gray matter, white matter, and the CSF.
Okay, sir. Thank you, sir. Thank you, sir.
And one more thing is there for imaging biomarker. So you can use 2Hg. There is a biomarker called 2Hg. That is a metabolite mutated in the glioma. Okay. So that is known as 2-hydroglutarate. I will just type the name. You can search
Okay,
2
sir. I will search.
hydro 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 hydroxy glutarate. I typed in the chat box. So this is one. Then MR spectroscopy is there. Okay, MR spectroscopy patterns. So not only normal MRI, MR spectroscopy is there. So in that case, elevated choline to acetyl straight. I will just type the name. Then it will be easy for you. MR spectroscopy pattern. You can search for this MR spectroscopy pattern. So these are the two main imaging biomarker. But the thing is, we need to get data for this. You can collaborate with any
Okay,
of the
sir.
research institute and ask for this data.
Oh,
And
yes,
if you are
sir.
able
Yes,
to provide, you can use that one.
sir. Okay, sir. Okay, sir. Thank you, sir. Thank you, sir.
Any other question? If you feel not feeling to ask any question, you can put it in the chat box. No issues. Hesitate to ask question, you can put it in the chat box.
Sorry, MRS magnetic resonance spectroscopy, whether any open source data set is available, sir? I don't think so.
It's not available, sir.
It's not
See,
available.
mainly the problem is most of the data sets are provided by the particular research institute, and it will be due to the ethical issues they won't share. So if you want to get a image, you have to first of all make an MOU with that particular research institute or the hospital. Then you have to collect your data, because most of the people won't share unless it is allowed to share.
Okay. Thank you, sir, for your insightful session, starting from clinical literature till the imaging technique and regarding DSA, digital subtraction angiography, MRS, MRI images handling, and research papers also we have discussed recent articles which highlights different methods for identifying hemorrhage, different types and with the different levels of accuracies. Thank you very much for your insightful session, sir. Thank you.
Thank you all for the kind support for the entire program. And I also would like to thank Narasimhan sir and Shastra for inviting me for a session. So thank you, sir. I hope you get some idea from my session.
Yes, sir. Sure, sir. Sure. Yes, sir. Yes, sir. Thank you, sir. Thank you.
Thank you. Okay, okay. All the best. And I
Thank
wish
you.
you all the success for your future.